Well, hello there, Healthcare Experience Matters listeners. We are back with a fantastic episode today. We have a panel with us today, and we will start out with introductions before I jump into my line of questioning here for our panel. And I'm going to start with the Healthcare Experience Foundation's Jim Kinsey, who's joining us. Jim, take it away.
Thanks so much, Casey. Hello, my name is Jim Kinsey. As Casey said, I am the director of the Healthcare Experience Academy, which is the Healthcare Experience Foundation online learning platform.
And we have a return guest, so I am going to reintroduce Timothy to our listeners. Timothy, remind us who you are, what you do.
Sure. Thank you, Casey. I'm so glad to be back. My name is Tim Seay-Morrison, and I work with Stanford Healthcare, and I lead our service lines and also our ambulatory care enterprise.
And joining our show for the very first time, I am so excited. Roberto, why don't you tell us your name and what you do as well?
Hello, my name is Roberto Rodriguez. I am a nurse by background and a senior director for faculty primary care operations at Stanford Healthcare.
Thank you. And so this is a reunion type episode in a way because Timothy and I last spoke in February 2022 on this podcast. It was a very popular episode that I will link to in the description of this podcast. So be sure to check that out after you're done listening to this one. And we were talking about burnout rates among medical assistants. So Timothy, I'll have you start us off here. Just remind us of some of the key findings from that initial study we discussed back in 2022. And then we're going to start to touch on kind of what's new since we last spoke.
Sure. We did study our medical assistants in 2018 and then also again, actually later in 2022, I think after maybe our first chat, Casey, but we were really looking to understand what was the impact of burnout and professional fulfillment on the medical assistants who we believe are so core and foundational to the success of our ambulatory practices. And we knew that we had studied physicians and advanced practice providers and used tools to think about their burnout and fulfillment and couldn't find anybody who had studied medical assistants. And so part of the study was to actually validate the tool and see if it worked with a different population of healthcare workers, which it did. The study found that. And I think the best parts of the study, both times we did it, were that medical assistants have less burnout and higher fulfillment than their other professional counterparts. And there are many reasons we might assume why that is. And partially they tell us they've got pretty good coping skills and they've got some control over parts of their job. But the things that they did tell us were important to pay attention to and had really strong impacts on burnout and fulfillment were, one, belief that their organization was committed to doing something about burnout, and that their manager understood what to look for and knew what they were doing. And secondly, that they had a professional development pathway. And so I think that's what we took away from both studies. I think we were really happy to see that even a year after COVID-ish or whatever that was, 2022, our numbers hadn't changed. And I think the fact that they were flat in performance was really reinforcing to us that our medical assistants were still doing okay, because we would have expected probably a plummet after COVID because they worked really hard through it. But we had flat performance and they held low burnout and high fulfillment.
Yeah. And I'm going to turn my line of questioning over to Roberto because we were talking before we actually hit record on this particular call, and we discussed how it took 3 years from the time everyone identified what needed to be done until it was actually implemented. So I want to, first of all, get your take on talk me through why it took the 3 years. And then Jim, I bet you will have something to add to this as well.
Yeah, it was a journey. I think for my learnings we have a very large organization with a lot of different operations and service lines. And so the majority of that time was getting alignment and also learning. What we started with, actually, we ended with something very different. And so what we first proposed, and we took that to operational leaders and to the frontline PCCs, that was a learning process. You know, one of the things early on, we use the term PCC, it stands for Patient Care Coordinator. And that's a medical assistant diploma or certification. But one of the things we were trying to get rid of our old ladder and we were just going to change it to medical assistants. And they actually had, the Frontline had a very strong visceral reaction to that because they took so much pride in being patient care coordinators. And so, that was a learning iteration for us to coming back. Okay, what are the things that we could do to engage this group? And it was multiple iterations over those 3 years to get alignment across the organization, both with the Frontline and then I would say at every level with the managers, the directors, the senior VPs, and ultimately our HR department to get us moving in this direction where we had overlapping alignment. I don't know if we could have done it any faster and ended up with something that was a proper professional development pathway that gave clarity on what you could do to get promoted and equity and opportunity. Those were the two things that we were shooting for. And I think what we landed at is perfect, but we did get those kind of pathways and opportunities for leadership built into it. So that is why it took so long, Casey, and a ton of lessons learned along the way that I'm happy to share.
So, Roberto, I have two follow-ups. First is, could you describe some of the elements of the pathway? What are some of the ways in which I can go through this pathway and get promoted?
Yeah, so there's 4 steps in our ladder. We used to have 5. And the first one is basically an entry. So no experience, but you have an MA certification or a certificate. You're welcome in, and that's what we call PCC 1. And then a PCC 2 is when you have some experience underneath that. It could be internal or external, and that's a year of experience is the minimum for a PCC 2. And that's like the base that we have for our population. And then from there we have a PCC 3 and a PCC 4. This was a learning iteration when we were working with the directors, because my question to the directors was, what's your differentiation between a PCC 3 and a PCC 4? And it was very muddled. It was really like we couldn't land on concrete things. And so what we did is like, okay, there's something that the PCCs are doing for those higher levels. Directors, put down your higher functioning roles, and that unique to each of your service lines, and we'll start to have that as a clear pathway for your PCCs. And then for the PCC4, we needed a differentiator. So what we landed on is a certification. So when they finish their MA program, they get a certificate, but a certification is where they go take a test from an accrediting board. And that has been the differentiation that we have for that higher level of the PCC4.
So thank you for that. I'm wondering also, because you've alluded to it a couple times, so the intentionality of going back to the existing PCC group to actually kind of co-design this with them. Do you credit, or could you credit that element, and also the element of building consensus with all of the other areas and departments and service lines? One of the things that I was thinking was, the initial study was in 2018, follow-up study in 2022, post-COVID, and you have the same results, which is wonderful to celebrate, and I'm pretty sure that you guys have. But what I really am trying to uncover is, what do you credit the sustainability with?
Yeah, that frontline perspective was so invaluable. We're lucky because we already had a structure in place to engage our frontline. It's called shared leadership councils. So it's something that comes out of nursing, but we've adapted it to ambulatory. And that is a place where the frontline has overlapping governance with management. And so it actually was coming through in those forums along from the operational leaders, because it wasn't working for the operational leaders or for the frontline. And so that platform gave us a really good engagement tool with the frontline without getting into any overstepping boundaries of a manager and their frontline employee. It was an already established forum where we could get frontline perspective. And then I think the openness from the operational leaders of us being able to go into their senior forums and share where we were at was the other side of the coin of where we were able to develop some alignment. Tim, did I miss anything on that? You were such a big player in developing that.
No, I think that, and maybe you'll want to talk about this a little bit, Roberto, but the other thing that why it took a long time to implement was a couple other things we needed to solve for weren't just about this 4-level ladder, but were the fact that we had mixed up supervision and leadership and a lead role into our ladder. And that was muddling a skill-based progression from a leadership progression. And so the team did a ton of work to get support and help design what does it mean to be a preceptor and get engaged in training other PCCs or onboarding new people to the organization, as well as a lead. Kind of in that charge nurse mentality, we didn't have any kind of way for our PCCs to even test out or flex their leadership capability before going into a manager pathway. And so we needed some ways to do that. And that had to come out of the ladder, get rebuilt, get tested. And I think the MAs, the PCCs, they really drove the need for that. And the operational leaders were super supportive. But, in a complex organization, it just took us a while to get through how does that map to other things? How do we get it in there? And we've landed on all of that now as a packaged ladder. And I feel really good about that part too.
Awesome. I think both of you are pointing out, and I'm sure some of our listeners have experienced this. Sometimes the path is long, but the benefit of that is that you're really looking at all of the layers and all of the potential areas that are touched by your program. And I think it's important for our listeners to understand that you could have taken a shorter path, except it would not have been sustainable and probably would not have been as intentional and not as well received. So sometimes when the path is long, there's purpose there, and really digging in and making it something that is received by all very positively. And it seems like that's really part of the path that you took.
We actually had done that. I think part of this is unwinding a fast ladder that got put in place, I don't know, X number of years before that to try to solve, a need. And we watched our leaders just struggle with implementing it. It created more problems for us. So this process feels much more sustainable. And our MAs tell us it feels better to them.
That's great to hear. Thanks for sharing that part, Tim.
Tim, tell me a little bit about patient care coordinators, PCCs, the naming convention. Those engaged in a traditional medical assistant role with Stanford Healthcare are referred to as PCCs. I find that interesting. Is there anything you wanted to tell us about that?
I wasn't here when it started, but as you heard from Roberto, it's we're definitely very attached to it, especially the folks here. I think that we're really lucky. We work at Stanford Healthcare, a premier academic organization. We draw really talented people who want to work in a complex environment. And that's true of medical assistants and nursing assistants and all kinds of non-degreed professionals who come to work with us, or unlicensed professionals. They're attracted to working in a complex place. And so I think it came from the fact that our medical assistants are doing a variety of things beyond traditional medical assistant tasks. They are engaging in the day-to-day coordination of care for patients and families because of the complex environments they work in. They specialize in specialties. And while that's not totally unique in the market, lots of medical assistants specialize in a practice field. I think that what's expected of them here, working in faculty practices and highly complex and even pretty acute ambulatory environments, the MAs are proud to do things beyond what they might consider an entry-level medical assistant would do. And so it captures the fact that we expect them to engage as part of the care team as a coordinator. And that skill level builds on their capability as care coordinators. I think it also comes from the fact that, they come from different backgrounds, and we've had people enter this profession who hadn't yet gone through medical assistant training, or maybe came from different types of disciplines. And we've used the job title in a couple of ways, which now is cleaned up again. But it also just helped us have a little bit more diversity in what our capabilities were too. Roberto, do you think I captured that?
Yeah, I think you did. In the ambulatory space, they're the foundation of care in the ambulatory space. And so they really are coordinating care. I think the name accurately catches what they're doing in their profession.
So, and this is for either one of you. I'm just curious if you has this positively impact your retention rate and your recruitment efforts for these roles?
We were talking
Roberto,
about that and wanting to look at retention. We, of course, we had a hypothesis that this would keep our retention, and it's hard to directly link it. And I think there's so many variables about retention, and we're in a very competitive market, and we're in a very expensive cost of living market. And so for people working as medical assistants, there are many, many things that would draw them to us or away from us, unfortunately. And I think it's hard to direct connect it. Of course, we want them to be retained, which is why we have that. And we want those of them that can stay and want to stay to be here for the long haul. But I think it's hard to put our to fix exactly that this is a causality of better retention. I think Roberto brought up with me earlier, we should be studying the promotion pathways for them, the rate at which they promote. We've seen lots of MAs in our system become assistant managers and managers, and I think, or take different career paths within our organization. And that's probably a metric that we don't have, we can't pull a field from any of our systems about that, but we should do some data analysis and connect some qualitative data on these folks to find that out, because I believe it's true.
I'm going to be almost sure that you're familiar with it, but there's a process called stay interviews where and if our listeners are not aware, it's really where you interview current employees that have been there and have significant retention years in order to find out why they're still there. And so Roberto, you had previously talked to Casey about the diversity and inclusion piece of this program. And the reason why I asked about retention is that there is correlation between inclusive environments and retention of staff, both in healthcare and outside of healthcare. So could you speak to the importance of that in this program specifically?
Yeah. Tim shared this. So I think the structure for our PCC ladder, we have the 4 levels, which are job descriptions. And then we added these 2 pieces that are just my absolute favorite, because I think it taps into exactly what you want to learn about, Jim. One is a lead role, and that's synonymous to what nurses use as a charge nurse role. And the other is a trainer role that's synonymous to what nurses use as preceptors. And those 2 roles are so powerful because, like Tim called out earlier, it gives an opportunity for formalized leadership without the commitment and the big jump of becoming a manager. And when I look at nursing, nursing has been so successful across all of healthcare of developing leaders in all areas of healthcare. And to me, in my path as a nurse and as a leader, that first exposure as a charge nurse is the stepping stone. And that's where you learn your core fundamentals of managing conflict, of leading teams, of keeping operations going for the day. And with this tool, now we're giving a group of unlicensed staff who are in our organization, 90% female, 90% people of color, opportunities for these formalized leadership roles and practice with it. And so what it means is that when they have those repetitions as being a lead, those are the people that are going to become assistant managers, directors down the line. And we're tapping directly into that group that we're trying to serve as a underrepresented group. So for me, I think this is a big step forward for diversity and inclusion. I encourage anybody else that's doing work in that space, how are you connecting with those populations directly and opening up those opportunities? Tim, please chime in on, you've done so much work in this space.
Yeah, you mentioned, I think, all the things that are really important to us, and paying specific attention to the demographics of this workforce and why it's important to us to keep it strong and reinforce the workforce. I think it also plays into the other kinds of things that have come from this work, are a reinvigorated externship program, because now we've got trainer capabilities among our frontline staff. They want to train people to come here. We want to attract people here. And so we're starting to pull from, the community colleges and other locations around us who are training medical assistants. And we have an infrastructure to receive them and help them. And then we can show them a pathway to a career that exists here. And many of those programs are also thinking about the diversity of the populations and the kinds of people they're serving going into those programs. And so we can be part of that and I think reinforce that and make it stronger here too.
Thank you so much for that. One of the last, my last follow-up is, Roberto, you mentioned conflict resolution, and so much of being a lead or being a trainer is really about developing those skills. And it's also one of the things that at the Healthcare Experience Foundation we do at all levels. And so I'm wondering what tools or in what way do you support the development of enhanced communication and conflict resolution?
We're lucky, Jim. We have a lot of resources in our organization. And so we have a crucial conversations course that our staff could go to. We have a formalized preceptor and lead course that we send them to. But I would say the most important thing is the repetitions of practice. And so the repetitions that they're getting actually being in that role is what's honing them. And that's why they're getting better at it, because they're practicing it. And it's different when it's a formalized compensated role. You step into it differently.
And you look at it differently, right? It's important to my role, but it's also important. Now I can see the importance to the organization. And certainly when I'm in a preceptor role, I can certainly understand a deeper way of communicating would only benefit that preceptor. Is there anything that either one of you, when you were logging on, said, oh, I want to be sure to say this?
One of the things that comes to mind is, like, we talked about the metric of turnover, which I think is a good one to keep on. But I think focusing on like Tim was calling out, how many of our PCCs are being promoted into management positions and going down whatever their leadership path is or whatever their career growth is, I think is another side of the coin that we need to keep our eye on and continue to invest in that. I do know in my areas, I have several leaders that were former medical assistants, frontline medical assistants or PCCs, and are now such successful leaders because they understand the operations from a level that an RN or an NP or APP doesn't. And so the organization is benefiting from tapping into that talent.
Awesome.
Yeah, just I guess the thing that I always like to talk about is how much we learned from studying the medical assistants twice, and how resilient as a group of employees they are, and how much they have to teach the rest of the system. And I think a lot of our other healthcare disciplines can learn from this group of employees. And I think they continue to teach us about what it means to have good boundaries, communicate well, take care of yourself, do a great job, feel good about it every day, and be there for patients and families. So I like their strengths really shine through.
Yeah.
Thank you for that. Casey, back to you.
Yeah. That was fantastic. That was Jim's way of saying any final thoughts. So I appreciate that. Jim, did you have anything else to add either before we sign off here?
No, just a huge amount of gratitude for the work that both of you are doing, the work that your teams are doing. As I said before the call, this is such an important part of my background and my career. Having started as a nursing assistant in long-term care, this always is important to me to see how organizations are promoting the role, changing the role, and really making it a profession that people can look up to and be proud of. So much gratitude.
Yeah, absolutely. I don't think I can say it better than that. Timothy, Roberto, and Jim, what a great discussion. Thank you all for joining us today, and we'll let that be the final word.
Thanks for having us.
Thank you.
Thank you.